Very good evening to all. I am Arpita from the IGCP group and I welcome you all to today's webinar on the topic tuberculosis in gynecology, the great masquerader of infertility. That's the topic. We have someone very of obstetrics and gynecology who doesn't need any introduction at all, but yes, it's an honor to introduce her to everyone. So I would like to welcome Dr. Ambuja Chunarun ma'am. She is an esteemed expert in obstetrics and gynecology with decades of experience in women's health. She holds an MBBS and DGO and is a recognized menopausal specialist currently practicing in Hyderabad. She has served as a of obstetrics and gynecology at Osmania Medical College, Hyderabad, institutions in our country. Through and clinical career, she has advocate for women's health, particularly in the area of menopause. Vast experience and her a highly respected community. We are really privileged to have ma'am with us today. So ma'am, with that note, I would now request you to please start the topic for today. Over to you.
Thank you very much, Arpita, for your kind introduction. Broken introduction, not a continuously, somehow it is broken somewhere like that. I'm very happy to be here today to talk about tuberculosis in gynecology. It's very much rampant. Many of us are scared also. In olden days, it's about 50 years back when tuberculosis person comes means we used to get scared because there was no treatment for that one and people invariably used to die. So no question of having the children or anything like that. Thank God BCG vaccination has come and tuberculosis got controlled. So the consequences of it now started. What is the effect of it on the female genital system that has started? And mind it, tuberculosis is 100% preventable and curable disease, which we should understand that. And it spreads by air, like when you spit or when you walk on the spores or anything like that, it spreads. So that is why when unhygienic conditions are there in third world, where developing countries, the incidence is more. But with hygienic conditions, with BCG vaccination, even in India, 50% of it has come down completely. It is not eradicated yet. But only problem is resistant infections are becoming more. Tuberculosis remains a major public health problem globally. 10 million persons develop active tuberculosis each year, and 1.33 million deaths occur every year. Naturally, it 1% only in the developed countries, and that is also in the migrants, it is more common. In developing countries, it is remaining all is there 85% of deaths occur in developing countries, mostly between the ages of 15 and 45 years. And as I already told you, multi-drug resistant and extensively drug resistant TB, which have high morbidity and mortality, are matters of real concern. So, a little bit about the global epidemiology. Female genital tuberculosis makes 9% of extrapulmonary tuberculosis. 90% of tuberculosis affects the lungs, especially in children. And extrapulmonary tuberculosis, 9% itself is in the genital tuberculosis. Among infertile women, when it is taken as a statistics, it is 20% of the infertile women are lodging the tuberculosis. And low income groups, it is 3 to 26%. And 88% of women with female genital tuberculosis experience infertility, and primary and secondary also is common. What about in India? It constitutes double the amount. 18% of the patients, the female genital tuberculosis are there of the total tuberculosis treatment. And infertility clinics, if you go, it is up to 48%. And ICMR study is being done always continuously. What it projected is it was in 2011 19% and it rose to 30%. Means instead of getting controlled, it is raising. Why? The resistant and extra resistant tuberculosis, rifampicin resistant tuberculosis is emerging, and which is a great danger to the humanity. And second thing that's more important is the HIV infection has increased. The incidence of extrapulmonary tuberculosis and female genital tuberculosis, both in India and Africa, due to poor immunity. Definitely, it is there. And genital tuberculosis, just to, everybody knows it, but I want to again reaffirm saying that it is caused by the Mycobacterium tuberculosis, this is a bacteria, and bacteria we have the bacillus and cocci. Among that, it is the bacillus that is there. Rarely, Mycobacterium bovis and atypical mycobacteria also is one of the causes, because I had a case of the infertility. Everything is negative, but she was getting continuously temperature and abscess formation used to be there, and it is a culture negative. Then finally, in Madras, we got the culture done, and it turned out to be atypical tuberculosis. So it's very difficult to treat the atypical tuberculosis. Usually, any female genital tuberculosis is secondary to the pulmonary tuberculosis. And mode of spread, one is hematogenous, because it is a secondary only, most it is not a primary tuberculosis. Lungs is different, where the sputum through the cough and all it spreads. But the female genital tuberculosis spread, one is by the hematogenous, second by the lymphatic spread, and direct spread from the abdominal tuberculosis can be present. There are high risk factors, definitely, like already enumerated: poverty, overcrowding, lack of health facilities, poor ventilation, diabetes, HIV infection, and sexually transmitted through the semen. This is one which always we forget, but if the husband is having a active tuberculosis, it's possible to infect the female. And if you go to the pathology, 90 to 100% of the fallopian tubes are involved. Both tubes, not one, both tubes. The three musketeers which involve the tube and produce infertilities, the first and foremost is the tuberculosis, next is the chlamydia, and third is the gonorrhea. And all the three are silent. They don't cause anything, asymptomatic, and finally the tube will be blocked. Always a blocked tube. Think of these things. And uterus is involved, endometrium in 50 to 80% of the patients, and ovary in 20 to 30% of the patients. The cervix and all is not very much involved, especially as far as the infertility is concerned. The major problem is with the fallopian tubes. I'll tell you how fallopian tubes are affected and causing the infertility. The fallopian tubes has got the exosalpinx. This is the exosalpinx, endosalpinx, and muscularis. Three layers are. All the three are affected in tuberculosis. So, endosalpinx patency may be present. Secondary infection with pyogenic organism, exosalpingitis, and interstitial salpingitis can occur. What happens in that? There is hyperemia, flimsy adhesions, and miliary tuberculosis on the surface of the tubes, later leading to the closed tube, tubo-ovarian abscess, hydrosalpinx, pyosalpinx, and the development of a synechiae formation occurs. But in the beginning, though exosalpinx and endosalpinx are affected, the tubes will be patent. That is why many of the people will end up with the ectopic pregnancy, because they are called specially lead pipe tubes. Because of the inflammation and adhesions, it becomes a stiff lead pipe like that. the tubal peristalsis will be absent. That is why it is called the lead pipe tube. Sometimes it will be open, and ectopic is the reason. Many a times it results in the ectopic. And yeah, this is about the tube, how it is affected. What about the endometrium? Intrauterine adhesions, see the endometrium, tubular cavity, and decrease in the subendometrial blood flow that will be present, and implant that leads to the implantation failures. Because of the intrauterine adhesions, the Usherman syndrome is the thing that happens. Whereas we heard about this Usherman syndrome, it is a vigorous curettage if you do it for MTP or for any other reason. That again leads to the intrauterine adhesions that's called the Usherman syndrome. The lesions can be focal or multiple ulcers. You are seeing here, and necrosis or hemorrhagic disease will be formed. Destruction of the endometrium may occur with Usherman syndrome, manifesting a secondary amenorrhea and infertility. On microscopy, typical caseative epithelioid granulomas, epithelioid cells, and specialized Langhans giant cells may not form because histopathology, whenever we talk about tuberculosis, what strikes our mind? Langhans giant cells will be present on histopathology. But it is not the case in the DNC specimen, what we do with the endometrium, because the epithelium is shed out every time menstruation occurs. So we may not be able to see the Langhans giant cells may not form due to the shedding of the endometrium during menstruation. Instead of that, when you do DNC, and if you see the presence of focal collection of lymphocytes on endometrial biopsies, it also indicates it can be female genital tuberculosis. This variation, you should remember, especially the pathologist first guide us for this one. This is what the first and foremost is the fallopian tube. Next is affected is the endometrium. Then next comes how the ovaries contribute to the infertility. The major problem is the primary and secondary infertility. It involves 30% of the cases, tube 90 to 100%, and 50 to 70% is the endometrium, and ovaries is 30% of the cases. And ovaries, adhesions, caseation, adnexal cyst or mass formation will be present. Defective ovarian function and decreased ovarian reserve because of the complete destruction of the ovary by the miliary tuberculosis. Sometimes tuber-ovarian cyst can manifest as acute abdomen, simulating acute appendicitis, and may be diagnosed on laparoscopy or laparotomy. Really, we had a case of a young girl of 20 to 23 years. She's, emaciated and she was anemic and all, but there was a mass per abdomen. We could not make out the mass. Those days, we never had any ultrasound to see also. Even if you have ultrasound, it's very difficult. Mass is there continuously. But she was not complaining much. But we did laparotomy. You see that it is a miliary tuberculosis where you could not do anything. We took a biopsy and sent it for histopathology. And believe it or not, she became all right. In 6 months, she became all right. So, diagnosis is very, very important. I'll tell you how difficult it is to diagnose. Once you diagnose, treatment is easy. For that case, we did laparotomy and we could take the biopsy. This is how the ovaries, the reserve ovary reserve is decreased because of the atrophy of the ovary. The whole ovary is involved in that one. And what about the cervix? Cervix is only about 1 to 3%, and it is the polypoidal growth or ulceration will be seen. When you put a speculum, it mimics as if it is a cancer. But biopsy only will prove that it is there. But cancer always, once you put the speculum, it bleeds. But the tuberculosis will not bleed. So you can take a punch biopsy and subject it for histopathological examination. Granulomatous inflammation will be made out. So next comes is the peritoneum. These are the five parts we should remember what happens to the pathology. One is multiple tubercles, miliary tuberculosis. Ascites is a major thing that can happen. Abdominal masses simulating ovarian cancer. But patient will have massive ascites, but she will not feel it at all. That is the major thing. A patient will, asymptomatic patient, but once you put your hand on the abdomen, a doughy feeling, that is what is the word used. You feel you are into the dough means what we do, atta dough, no? Like that, it goes inside and you will feel the ascites. Always you suspect ascites means where else you will see the ascites? It's in the malignancy, it will be there. So ascites, if it is present, or cirrhosis of the liver. But ascites, you should think of in a young patient. If she comes, always think of the abdominal tuberculosis, especially in the case of infertility. And abdominal masses will be present. And perihepatic synechiae is one of the things we should never forget. This is called the Fridtjof-Curtis syndrome. And gallbladder will be hanging. That is what is the thing they call it as gallbladder will be hanging and ascending colonic synechiae will be present. And this is one of the reasons to have the frozen pelvis, means you can't put the scope or you can't do the laparotomy, also frozen pelvis. And I think many of the students are there. Once you say frozen pelvis, what is the differential diagnosis? There are three conditions where you describe it as a frozen pelvis. One is tuberculosis, already I am dealing with. Second is malignancy anywhere, especially ovarian malignancy, fourth stage where abdomen is involved. And the next foremost important thing is the endometriosis. So the minute you say it is the frozen pelvis, this all should come into your mind. Ascitic fluid sampling for biochemical analysis, increased adenosine deaminase levels, and peritoneal biopsy may confirm the diagnosis of tuberculosis and thus can avoid laparotomy. Once you dig into this frozen pelvis, you are nowhere. You can pray God. You put both your hands and pray God because you will end up where you don't know. And female genital tuberculosis and endometriosis may present together in some cases. Just now I told you what are the reasons for the frozen pelvis. So this is how the pathology exists. First is the tube, second is the endometrium, the third is the ovary, and fourth is the peritoneum. Of course, the cervix and all, not much we see, but these are the four culprits that produce the infertility. Clinical picture, how it comes: 10% of the cases are asymptomatic, and infertility 35 to 60%. They just come to us without any signs and symptoms. I'll tell you later what are the signs and symptoms. By investigations, you will make out that it is the genital tuberculosis, and patient will be hale and healthy. And menstrual disorders will be present in 40 to 50% of the cases. That is, in the beginning, it can be excess menstrual bleeding. Later on, she may go in for the secondary amenorrhea. I already told you Asherman syndrome producing the secondary amenorrhea. It is there already. Oligoamenorrhea and secondary amenorrhea. Pain in the lower abdomen in 40% of the cases. Low grade fever, malaise, weight loss, mass, encysted ascites, doughy feeling, all these things they may present. And pelvic mass usually non-tender unless superadded infection is present. And pelvic mass ill-defined. Any mass it will be present. How do we define? It is the margins where they defined or not. What is the size of the mass? How are the margins? Is it a tender or not? These are the five. Yes, we will tell about the swelling that is present. And here it is a vague mass, non-tender, and you will not feel the margins at all because it is because of the adhesions that will be present. And one more thing we should never forget is the postcoital bleeding or irregular bleeding PV because of the cervix. If it gets involved, it is very rare. It can also present like this. So coming to the cause of infertility, just it is again, I'm telling, because these people, they asked me to talk about the infertility in the tuberculosis. So I just want to enumerate again so that it will be fixed in your mind. One is the tubal factor, where unilateral and bilateral tubal blockage is present. Again, because of the endosalpinx, exosalpinx, and mesosalpinx involvement, and loss of tubal function due to ciliary damage. I told you motility will not be there. Perisalpingitis causing adhesions and tubo-ovarian mass formation, and unilateral or bilateral hydrosalpinx with or without obstruction, affecting fertilization and embryonic implantation. And defective ovarian function, endocrine dysfunction, chronic anovulation, antigonadotrophic effect because of the mycobacterium tuberculosis, even that is why repeated in vitro fertilization failures also are present because of this antigonadotropic function. Poor quality of embryo on oocyte will be produced, and there is a luteal phase defect. All these things leads to the implantation failure. What about the uterine factors? And it is the affects endometrial receptivity, leading to endometrial atrophy and synechial formation. You should never forget about the immunological factors because of the mycobacterium on the endometrium. Usually, it produces TH cells, that is, thymine 1 cells are generally considered protective, promoting macrophage activation to kill intracellular mycobacterial tuberculosis. T2 cells promoting inflammation that can exacerbate disease. So this is the latest one that is there to diagnose what type of cells that are present in the endometrium, to say the treatment what you are giving is going to be successful or not. Because of the mycobacterium tuberculosis on the endometrium, immune cells will be generated. There are two types of immune cells, T1 and T2 cells. T1 cells are good, and T2 cells, if they are present, it eats off the macrophages in the endometrium, produces inflammation, and that can exacerbate the disease. So recently, this is one it is taken to diagnose the type of immunity that is present. And if it causes repeated IVF failures if T1 cells are present. So I told you these are all the things that can happen, how it produces the infertility. So what are the diagnostic challenges now? One is gold standard is the conventional methods. We know Langerhans cells will be there. That is the histopathology and microbiology, where you see the acid fast bacilli and culture if you do it. And conventional methods will detect TB only in 15 to 20% of the patients. What about the others? So difficult dilemma when conventional negative, these tests are negative. Case definitions for female genital tuberculosis in the absence of conventional methods. So what we should do, it is the combination of all these things. That is the bacteriology, histopathology, molecular methods, and laparoscopy or hysteroscopy is done. More than anything, especially in the menstrual fluid, already I told you, you will not see the typical giant cells, typical Langerhans cells, even if you do the culture, because of the repeatedly shedding out of the endometrium. So, if a collection of lymphocytes are there, it also is taken as the tuberculosis. How do you diagnose? One, by history. What is the history? Patient always says evening rise of temperature, patient will be anemic and exhausted, loss of weight, loss of appetite, and on general examination, lymphadenopathy, especially in the cervical glands, and matted lymph glands will be present, and X-ray examination, X-ray you take because pulmonary tuberculosis is very common. You will see the cavities that is present, and infiltration of the lungs also will be there. And you can see the spine, sometimes it is affected. Ascites can be present. And per abdomen, I already told you, mass can be there. And per speculum and PV examination are very important. It is a any mass which is non-tender and asymptomatic and non-tender, asymptomatic. She will not complain, only you will detect it. And associated with the ascites in a emaciated patient, always two things will come into mind. One is the cancer, second is the tuberculosis. If God comes and asks the question, what do you prefer, either tuberculosis or cancer? Always say tuberculosis because it is 100% cure rate is there. Only thing is you should diagnose it. That's what is very important. Now we'll go. What investigations you'll do? A minimum investigations before diagnosis, which is done. Apart from the total blood count and differential count, ESR, Mantoux test, you will do ultrasound examination, abdomen and pelvis, transvaginal ultrasound. But always ultrasound, both combined, you should do per abdomen and TVS because both are complementary to each other. The next comes, I all told you, Mantoux and ESR are very, very non-specific tests. And the detection rate with this is only 10 to 20%. Why? ESR is increased in so many conditions. Even normal pregnancy also ESR is increased. Mantoux test will be positive because BCG is given to each and every child because it is a universal immunization program that's being done in India. Mantoux test will be positive. So we cannot take that into consideration now. So interferon gamma test is the one. And premenstrual EB, if you take, you will be able to detect granulomas and histosalpingraphy, rigid lead pipe appearance, bleeding of tobacco pouch appearance, and pyosalpins can be present. Histoscopy, laparoscopy in selected patients. I will tell you when we will do all these things. So, active tuberculosis detecting is easy, especially in children, and it is a WHO project. Government will take care and it will detect. But where is the problem? Latent genital tuberculosis, if it is present, it's a big diagnostic dilemma. It presents either with infertility or recurrent miscarriage or abnormal uterine bleeding or postmenopausal bleeding. That's how it becomes very difficult. It misleads the diagnosis. That is why it is grossly underreported due to lack of good tests in virtually symptomless patients, and latent tuberculosis remains undiagnosed many a times. So, which test to confirm is the thing because ESR is not going to confirm, Mantoux test is not going to confirm, and the biopsy also menstrual fluid we cannot confirm. So, what is the best? Can we do serology, IgG, and IgM? Not to be used. It is 2011 WHO declared it is not going to be of help. It's not used. So I already told you ESR did not pick up the, yeah, they did not pick up latent tuberculosis like female genital tuberculosis. Either you take X-ray test which shows the past events that is there, or and histopathology Cox also Langerhans not to be found in many cases. And CBC, if you do it, it is only anemia, raised leukocytes and lymphocytes, and raised ESR will be present in TB, which are all non-specific things. So, excuse me. Can you please excuse me for just 2 minutes? Oh, Naman, madam. Half an hour, madam. Yeah. So we know that conventional methods can diagnose only 15 to 23% because of the paucibacillary infection that is there. What do you mean by this paucibacillary infection? Means this tuberculosis refers to a form of TB infection characterized by the low bacterial load, making it difficult to detect with conventional methods like as a AFP smears and all. This often occurs in the smear negative pulmonary tuberculosis and extrapulmonary tuberculosis. To diagnose can be, it's a challenging, often relies on more sensitive techniques like polymerase chain reaction culture or newer molecular assays. So, what is that? They are all because this extrapulmonary tuberculosis like this, AFB staining are all, or we are very familiar with the Lowenstein-Jensen's culture. That also at least 100 bacteria bacilli must be there per ml to detect. So all these things are going to fail. What next? So PCR and interferon gamma test are only now, it is accepted from June 23, 36% pickup rate is there. So what is this interferon IgRA test? Interferon release assays. Immune-based test indicate cellular response to recent or remote sensitization to Mycobacterium tuberculosis. Quantiferon gold, quantiferon gold in test in tube and T-spot test. This is called the quantiferon gold or quantiferon gold in T-tube test. Or it is alternative to TST or Montus. Results unaffected by BCG vaccination status, high specificity 96%. Even in BCG vaccinated individuals, detection of latent TB is possible. So, interferon test is the widely used now. This is the test it is widely used. Rapid culture methods, yes. Radiometric culture using the Bactec 460, but though it is a higher detection rate, higher sensitivity is there, it is disadvantage is it is a costly. I'm not going to deal with it now. So now we accepted molecular methods of polymerase chain reaction. That is the DNA molecular chain reaction by the DNA. Detection rate is 22 to 44% and positive even after full course of anti-tuberculosis treatment, and false positives are there, but it's only 10 to 12%. And now reverse transcriptase PCR that is there, but it is technically challenging. So we are using the PCR DNA test. Histochemistry based test, that is the monoclonal tubercular complex detection. Sensitivity and specificity for this monoclonal tuberculosis challenge test is very high. It is still underway, not it has come very high. And this we should remember. This is the CBNAT and NAT gene expert. Cartridge based nucleic acid amplification test. This is the CBNAT. It detects M tuberculosis DNA, high sensitivity and specificity, and quick results within 2 hours is there. But right now, what we are using is the interferon test right now, but they are all under thing. We have recently associated that cell-mediated immune markers, that is tumor necrosis factor alpha and interferon gamma are raised in patients with genital cox. This we have made out. So this is the second run of trials is going on with this. Association of cell-mediated immune marker, that is TNF alpha, interferon gamma, it detects latent genital tuberculosis. Means because of the immunity, you will be able to detect type 1 cytokine production or type 2. What is present in the endometrium, you will know because type 1, if it is present, it produces the It is the reason for causing infertility and recurrent miscarriage. If you detect type 2, then you can say that pregnancy will be successful for that one. So, type 1, if it is present, reproductive disaster will be there. And type 2, there will be a successful pregnancy. We can predict how it is going to be. After all these things, is there any vaccine for the adults? We know BCG vaccine is there for the children. It is universal immunization. In India, 100% immunization is being done. This is under trial. Uh, it is being developed for two purposes as a more effective vaccine than BCG for newborns and for the prevention of TB disease in adults and adolescents for whom there is currently no effective vaccination that is there. Because BCG vaccine, what is given, is not protective 100%. That is why people are getting all the extrapulmonary tuberculosis. What is the role of transvaginal sonography in TB patients? That's very important. I told you. First is the history, then general examination, then transvaginal examination, transabdominal examination. Transabdomen, you will see any mass that is present, ascites that is there, all these things. In the transvaginal, is there any way that you can suspect and detect? Because diagnosing tuberculosis in the genital genital tuberculosis is very, very difficult. It is not like a pulmonary tuberculosis where the patient comes with a cough and it coughs will be positive and all. No, here detection is very difficult. So, is there any clue that we are going to get by doing the transvaginal sonography? Yes. What is this clue? When you do transvaginal sonography, persistently thin endometrium is a common finding because the endometrium will change from proliferative phase 2 millimeters to 12 millimeters in the secretory phase. That will not be present. And whatever endometrium is seen, it appears broken and bright echogenic endometrium will be present. This should make us suspect that why the endometrium is thin. And peri-ovarian inflammation and speck of calcification on ovarian surface will be present. That maybe it's very difficult to make out unless is a very good sonographer. And TMOS is saying this is very important. Unilocular or multilocular thick-walled mass. See, you are able to see the thick-walled mass here with the diffuse internal echoes and layering effects seen when debris settles down. Outer margins are poorly defined if adhesions are there. And when you do the pelvic examination or you move the probe thing, it is a restricted mobility will be present. That is in the frozen pelvis. Whereas you will see this restricted mobility when you do the pelvic examination, it is in the endometriosis. Difference between this and that is here it is not painful. Endometrium, dyspareunia, and pouch of Douglas, pain will be present and restricted mobility. That is the restricted retroverted uterus will be there in endometriosis. Here, restricted mobility is another case where it is restricted. And another finding is PID with no pain is most important symptom or sign. It may be present as a fluid collection in cul-de-sacs. Ascites is one of the things that can occur when the peritoneum is involved. Wherever there is inflammation and irritation of the peritoneum, there is ascites. That is why in malignancy ascites is there, and endometriosis, last stage is ascites, and cirrhosis of the liver, yes, ascites will be present. Here again in the tuberculosis. The fluid collection in endometrial cavity and fluid collection inside the tubes, if adhesions at femoral line, fluid shows a definitive oblong expansion will be present. So always suspect this type of thing is better. So laparoscopy, I don't want to talk now about it. Laparoscopically, it is classified as the Definitive diagnosis, tubercle caseation, beaded tubes are present. Sometimes, so many times we do laparoscopy for primary infertility to see how, because here it is all the symptomless, is only very rarely the infertility only is the symptom they present. So we do laparoscopy. So sometimes the tubercle caseation, if it is present, a definite diagnosis, probable encysted fluid collection, dense pelvic and peritubal or periovarian adhesions if they are present, hydrosalpinx, steatomas, thick fibrous tubes, mid-tubal blocks, extravasation of dye or chromoperturbation, all these things is a probable diagnosis. Possible, mild flimsy adhesions, dilated tortuous tubes, and cornual fimbrial blocks, fimbrial agglutination, phimosis if it is present. Always your suspicion is very important. Take a biopsy and send it for the histopathological examination. Even by doing the histography also, histoscopy also, we can make out, because all of you must be very familiar whenever the infertility patient comes primary or secondary. After about 6 months of treatment, we'll post them for the diagnostic hysterolaparoscopy. So when you do it, it should give us the suspicion, especially secondary infertility. We will never suspect it can be tuberculosis. So always keep it in mind, it can be there. So this how it will be. It is a pale endometrium. You are able to see here that will be present. Intrauterine synechiae of varying grade, completely obliterated cavity in about 80% of the cases. Granulomas, poor distensibility, and narrowing of the uterine cavity will be present. So gives the suspicion of the thing. So you have diagnosed, you have suspected, and you have taken all the precautions. You diagnosed the tuberculosis. What about the treatment? How are you going to treat the genital tuberculosis? Always remember DOTS. Must be familiar with this word DOTS. The WHO introduced this DOTS program. What is this? This is the directly observed treatment, because it's more in the developing countries. People, they don't use it uh, continuously. They do so to see that complete cure will be present. It is a strategy developed by the World Health Organization to combat tuberculosis. DOTS involves a healthcare worker or designated individual observing TB patients take their medication to ensure they complete the full course of treatment. Always it is a free treatment for the tuberculosis from the government of India under the supervision of WHO. So what is the treatment? Very simple. First 2 months, four drugs will be given, and next 4 months, two drugs were given. What are the four drugs? And INH, rifampicin, ethambutol, and pyrazinamide. These are the doses. I don't want to, because to remember also is very difficult. But before doing any of the things, always we should do the liver function test, renal function test, CBC, ESR, because they are all hepatotoxic, and neuritis can be present. So hyperuricemia is one of the problem with the pyrazinamide. So always do the basic investigations and then you start the drugs. First 2 months, it is the four-drug regime: INH, rifampicin, ethambutol, and pyrazinamide. Why this DOTS is increased is many of these drugs, they produce a lot of nausea, vomiting. They just don't like to take these tablets. You give antiemetics, see that they will eat well, high protein diet to be given. For all this supervision, Government of India gives 1,500 rupees per patient per month to the patients who are registered in the centers, to see that they will see that nurses or designated IS will go to their house to see whether they are continuing the treatment or not. This is the DOTS program. It's being done very well. And for the next one, soon to only two drugs, that is the INH and the rifampicin. Are we justified? Next question comes. All the tests are negative. Are we justified in starting ATT on the basis of positive molecular test, histochemistry positive test, with no other obvious clinical features? Patient has come with infertility, but these tests are positive. What are we going to do? Yes, tuberculosis endometritis, you should start the treatment. After all these things, are we going to do surgery for this patient? Is there any indication? I told you, medical treatment is 100% curative. No need to do, even when you put a scope and see the type of tubercles are present, please take a biopsy and close it. Don't meddle unnecessarily. You are going to do more harm than good. Don't interfere with any of the things. Don't do, even when you do hysteroscopy also, don't put fluid because dissemination can be present. Once you see this type of images, please close it. Please stop the surgery. But is there any indication for surgery? Yes. Persistence of large masses despite medical management for 9 months, you have to take up for surgery. So I think to a certain extent, I made it clear about the female genital tuberculosis, how to manage, how to identify, how it is going to produce the infertility, and during infertility also because of the uh, immune histochemistry that is being done with the TH cells 1 or 2 with the detection of all these things, we can see the treatment, either IVF or miscarriages, is it going to be useful or not? Improvement will be present or not? So we have come to that extent to treat. So to conclude my talk, I can say latent genital tuberculosis contributes significantly to infertility. Suspicion raising tests are Montus, transvaginal sonography, histoscopy, and laparoscopy. Latent genital tuberculosis is diagnosed by PCR and MTBC test and interferon gamma test. TB, if treated, gives very satisfying success rates of infertility, but cure starts with detection. Suspicion and detection is very important. Once you diagnose it as TB, yes, wherever you go, they will give the treatment. Only thing is you have to detect and do it. So thanks, I just simply for giving me the opportunity to talk about this with the my students. Most of them are students are there. Thank you very much. Hello, hello, Arpita. Hello, am
Yes,
I
ma'am,
on?
I'm there. Yes,
Uh,
yes,
uh,
yes, ma'am, you're audible.
did you hear my presentation at all? Because there is no
Yes,
response
yes, ma'am.
anywhere. Okay, okay.
Ma'am, one minute, ma'am.
Hello. Any questions?
Yes, ma'am, we have received. I will be reading them out to you, ma'am. Ma'am, the first question is how can clinicians differentiate, distinguish like genital TB from other causes of infertility during early evaluation?
The suspicion is, first of all, is very important. Always we do the tests. The basic tests also is important. Don't take away because whenever the lymphocytes or TCDC, ESR, when you do ESR raised to more than 100, always suspect either tuberculosis or cancer. And because the genital tuberculosis, most of the time symptomless, they come only with the infertility, no loss of weight, no loss of appetite. I'll tell you one patient, she was so nice, beautiful looking. She came from Gulf country. And when I put my hand on the abdomen, there was ascites. How to tell her because she came with the infertility and ascites and ESR is raised. So I sent her immediately for the ultrasound examination. Lot of fluid is there. And aspiration of the fluid and examination revealed it is the tuberculosis. Minded treatment cured her tuberculosis, but she did not become pregnant because it is a extremely late stage. So suspicion is very, very important. When the infertility patient comes, you do investigations, male and female, and see where she lands up finally. These are all the tests we should do and find out.
Right, ma'am. Thank you so much. The next question is, ma'am, are there any red flag symptoms gynecologists should watch for, especially?
Yeah, red flags, you mean in infertility or detecting the tuberculosis only? Any tuberculosis in India, that is the diagnosis, you should never miss it. A patient comes with the menorrhagia or, excess menstrual bleeding or with the infertility, it should be there in your mind. And second is the classical symptoms to take the history, like evening rise of temperature, cough, which is not responding to antibiotics for 1 month, or cough with expectoration if it is present, night rise of temperature, and loss of weight, loss of appetite, especially in the reproductive age group or a adolescent and reproductive age group. Always the first suspicion is the tuberculosis. Then next you think of other things. And if there is nothing we could make out, we'll go usually for any patient having a normal uninterrupted intercourse for 1 year, definitely 80% of the people will conceive without any, if they're using without any protection, if it is there. And after 2 years, if they are not conceived, means there's something wrong. You investigate the patient and think of tuberculosis is one of the diagnoses and do it. And after giving the stimulation, ovulation stimulation and all 6 months, if they are not responding, still you are not able to make out what is the diagnosis. We post them for the histolaparoscopy, diagnostic histolaparoscopy. So I told you histolaparoscopy, how it is going to help. The transvaginal ultrasound, abdominal ultrasound, and histoscopy, and laparoscopy, how we are going to suspect and diagnose. Okay, shall I take leave?
Thank you so much for the effort for the session.